that alk phos will come down, because I do feel my bone pain is actually better. I feel I'm less stiff and less painful. So anyway, I'm blasting this with everything that you could blast it with, and interestingly, between the Xofigo and the enzalutamide, that's 18,000 bucks worth of drugs every month. So I'm feeling all that healthcare insurance I paid for over the years. I'm using it, man. I am using it up. So I'm the one that Hillary Clinton's talking about, basically, right here with the
Steve.
Yeah.
Could I add something? I just got off of the Xofigo. I only had 3 because it wasn't doing anything with the PSA and climbing, but I had the same response as you, except for the pain. I did have, after the 3, and even now, I have a lot more freedom of movement. So I don't know what, if that's the pain, the bone pains went away and things like that. I just thought I'd add that. So
Albert, you really shouldn't follow PSA on Xofigo, only alk phos. Was the alk phos coming down? Alkaline phosphatase? Because PSA is all over the map when you're on Xofigo. And you can't, even if it's going up, I recommend you continue on this sort of support.
I'll mention it. I'll mention it to my oncologist. On that, I read the same thing, that there wasn't a one-to-one correlation with the radiation and the PSA. So.
But if you're alk phos, and if you haven't done an alkaline phosphate level in a while, that's what tells you whether or not the Xofigo really is working.
Okay.
So it's not the PSA. The PSA can be all over the map.
Yeah. What should you see with the alk phos?
It should come down. Alk phos, alkaline phosphatase, or bony alkaline phosphatase, it comes from either the liver or the bone. Bony alkaline phosphatase is a measure of blastic activity or disruptive activity of bone. So as the bone is being chewed away less by the cancer, you expect the alk phos to go down. And so that's what most people will follow on Radium 223 is just the alk phos. Many people don't even recommend doing the PSA for the 6 cycles at all because it really completely unpredictable response.
When I started my chemo 11 months ago, my alpha phosphate was at 324. So there was quite a bit of bone activity at that particular time. Right now it's about 32. So it really does give you a better or another marker for this prostate cancer we're going through, and PSA only becomes, after PSA is over 100, it just becomes another marker. But watching your bone activity and the alpha phosphate, I think, is a good marker, as Steve said.
Steve, I have a question for you. I have a question for Steve. Are there 2 alkaline phosphatase? There's one for bones and one for non-bones?
Well, technically there are, but when you order a test, you just order an alk phos, and then if it's high, sometimes, and you can't explain, sometimes you titrate whether it's bony alk phos or hepatic or liver alk phos. But if it's high and you have prostate cancer, you just assume it's bone, it's not liver in general. They do liver function tests to look at that, and so no, when you order that test, it's just an alk phos. The other thing I learned about Bayer, which is a company that, of course, distributes, markets, and distributes Xofigo, is that they'll only give you 6 doses lifetime. That's it. So you get 6 doses, and they'll only dispense it once they've seen a hematocrit over 30 or hemoglobin over 10. They won't dispense it, so you have to have a CBC, a complete blood count, done within a week, and that hemoglobin has to be at least 10, and the other white count and platelets have to be in order as well. And you only get six of them. And so actually, Albert, interestingly, I was thinking of doing 3 Xofigo injections and then giving it a rest, and maybe in the future I can hold back and do the other 3, because once you use up your 6, that's all the company will dispense, at least right now, until there's more clinical trials on more than 6 cycles.
Has there been any work anywhere? Has there been any work anywhere on splitting the Radium-223? I haven't seen any, but it's an interesting idea.
I haven't seen it at all, but I've been thinking about it, and since you only get 6 lifetime doses, you want to use them wisely, So I guess I'll see. You'll see.
That's a good question. That would be a good question. Just just to say, that would be a good question to ask your rad-onc. I forget what's his the nuclear medicine guy that you see.
Yeah, no, Ryan Niederkort. No, he's the one that told me Bayer will only dispense 6 for this individual. You can't, because somebody on this call one time said they had gotten 12, and I'm just not sure how they had done that.
No, I don't think so, Steve. I don't remember. There was a trial where they gave 5, and yeah. Jerry was on that trial, and there was only 5 shots in the trial, but I've never heard of anybody getting more than 6.
Then it was on the Inspire site, Rick. Somebody had said another 6.
It was on Inspire. It was on Inspire, and I asked the Bayer guy at the conference last month, and he said that there are doctors that might do it off-label, but it's not, it's not recommended by the company. The company can't back it up, but there are doctors that have done more than 6. So my question is, on average, or how?
Did everybody lose Peter?
Find it might go for years.
Peter, can you repeat, because your internet is freezing you a little bit. Try again.
No, that dial-up, Peter, is no good.
I know, I get that. Everybody else. I'll try dialing up. So
yeah, really. Yeah.
I will. How long can you expect the alk phosphatates to keep low with these treatments? Do some people go for years with relief, or does it start creeping back up at a certain point?
I don't think, what I've read, and I've read a fair amount about Xofigo, I mean, if you get a good response, you can't consider it a remission. Prostate cancer is like a magnet to bone, and if there's viable, cancer cells circulating, they're going to be attracted to bone. So it kills the cancer cells that are in close proximity because it emits an alpha radiation. But, even if it kills all of the cells in your bone, at some point it's going to recur. And that's why I think it's important to, think about 6 versus more, because it's the only targeted therapy, when you think about it, we have for prostate cancer, other than Xifileucel. Other than that, is the only targeted therapy. The rest of it's just shotgun, really.
Right.
Any other questions?
Mike, are you listening to this Mike, are you listening to this conversation? Because it's probably something we should bring up next week.
Yeah, I am listening to this conversation. I am listening to this conversation, and it brings me to the thing about Xgeva too. It's like you only get so many, and it's supposed to last a long time. Why should I be taking them month after month after month and not spread it out? That's another question, but no, I am listening.
No, it's fine. I mean, we can talk about that. And by the way, Mike, are you getting any bone pain this month from your first Xofigo shot?
No, actually, I'm feeling much better. I'm feeling much better.
Good. You sound good.
I don't know if it's because I stopped taking the
abiraterone, the Zytiga.
Yeah, no, the one Peter's taken, Casodex.
Oh, Casodex.
Casodex.
When I got off of Casodex, life improved. I feel a little bit better, but it's just fatigue and I feel better. I got another one coming up. I don't know if it's working or not. I get my blood test this week.
Okay, so and, I think that you should be sure, maybe Peter, you can be sure that they're testing alkaline phosphatase for him.
They are. They're for sure. They're testing that, and he did a blood test this week, so he'll get the results.
Okay.
At the end of the week.
Okay. Okay. So I mean, I want to just endorse one thing that Dr. Steve said, which is that really don't follow your PSA. What's important is the alkaline phosphatase. What's important are your scans, but even your scans can be deceptive because the scans pick up bone activity, and bone activity can come from both the bone, the cancer creating more bone, and or the tumors receding, and both can create bone activity. And so it's not always a great guide off of one shot. There's got to be some time in between, and then you've got to be comparing the shots. Wouldn't you agree with that, Steve?
Yeah, no, bone scan, other than seeing new lesions where there were none before, is pretty worthless. If you're seeing, you know, it's lighting up in the same areas, as Rick is saying, it could be healing, repair, as well as clastic or breaking down of bone. So the alk phos is a pretty good marker, not ideal, but pretty good for Xofigo. And if it's going down and you're feeling better, I personally would stay the course. I think it's the only thing that's been proven to both prolong life and improve the bone pain. And it's very expensive. You know, it's $5,000 or $6,000 an injection, so it's not cheap. So you got to make sure your insurance is covering it. Needless to say, but for me, so far so good. I've had 3 weeks out from one injection, and I felt pretty good, really.
Anybody else have any questions for Steve, or do we want to talk any more about Xofigo?
One other quick comment about the enzalutamide. You know, enzalutamide, you know, I read through the FDA, or, you know, yeah, the FDA circular, you know, the packaged insert that comes with the drug when I got it. And, you know, it said, you know, like 1%, a little less than 1% of men have seizures on this drug. And that's, I mean, a 1 in 100 chance of having a seizure didn't sound very good to me. You know, abiraterone doesn't have that.
Right.
In the trials, abiraterone had a same as placebo incidence of seizures. So I looked into it, and I looked at the data. And then I ran this by Andrea Harst-Stark, who is our Rick and my friend, and she's a oncologist in Oakland, California. And so it turns out out of the several hundred people on the clinical trial on enzalutamide, there were 7 seizures. That gives you your 1%. And of the 7, 3 turned out to have brain metastases, and 1 was an alcoholic who was actively drinking, which is a good reason to have a seizure as well. So 4 of them had good reasons outside of the enzalutamide to have seizures. And then if you just took the other 3, that's pretty much a baseline for what you'd expect in alignment with the people taking placebo in the clinical trial. So when I first looked at that, I thought, oh shit, man, maybe I should try abiraterone instead, because I don't want to have a seizure while I'm driving or something, you know. But I think the incidence of seizures was built up in the clinical trial because of those 4 out of 7 patients who had a good reason to seize. So, and that's what Andrea agreed with as well after I talked to her about it.
Now, Steve, I have a question. So you use Kaiser?
Yeah, I'm Kaiser, yeah.
Now, does Kaiser pay for the Xofigo?
Yes,
Is that part of your insurance program?
Yes, yes. Or
your program with Kaiser? So, I mean, they've told me that because when we've talked about Xofigo, that it was part of my program. I wouldn't have any additional costs out of it for Xofigo.
Absolutely. There's not even a $5 copay, but they're pretty particular about you making sure that the boxes are checked. In other words, you have castrate-resistant disease, you have bone pain, you clearly have bone metastasis, you have a Radium PSA. You know, they check all the boxes there, and they don't want to do it off-label without all the boxes checked. So, you know, if they ask you to have bone pain, I would say yes. You know, that's
right.
Do they pay a 100%?
Yeah, it's 100%. Yeah.
What about your pills? You're like enzalutamide.
$5 every 3 months. They don't know. Mine's $5 every 3 months.
Oh well. When I was on Zytiga or on Xtandi, and the other only because I'd hit my maximum. But it was costing, I think my copay on both of those two drugs was about $2,700.
Yeah, it depends on your drug plan. Medicare Part D, you can assign it to Kaiser, and it depends on if you have supplemental insurance or not. But there's always going to be a ceiling. It won't be like, enzalutamide is $11,000 a month. So you're talking, what, 100 and something thousand bucks a year. It won't be that much. It'll be a ceiling after probably a month.
Yeah. Well, with Medicare and the tiers that they have, once you've spent $4,800 or something, whatever it is, on drugs, then your specialty tier is $12 at Kaiser. Yeah. Yeah.
So, and that's not just Kaiser. That's anyone on Medicare. You're going to have, depending. You can buy supplemental type D, Part D insurance to cover everything. My insurance happens to be very good, and it's just $5 for 3 months is what it cost me.
Wow, that's excellent.
So Steve,
I wouldn't know if I'd be taking it.
Steve, this is Len. I'm just curious, what made you decide to go with enzalutamide rather than abiraterone?
I listened to the video that Rick distributed from Truck Ryan at UCSF, where he looked at one versus the other. And the major difference as I see it is you need to take prednisone on the pardon me, abiraterone. And so it was a sort of a toss of the coin, and more than anything, it wasn't based on data. And I talked to my two oncologists, and both of them seemed to have a preference. Their experience said the enzalutamide seemed to be better tolerated. And I must say, after been on it for a little over 2 weeks, I feel pretty good. So it wasn't any scientific decision. It was more just what they said, and the fact that this way I wouldn't have to be on prednisone, which is not good in any case because of bone health, and I'm not on Xgeva or any of the bone, the bisphosphonates, which are the drugs that you take to thicken your bone. I'm not on any of those right now, so I figure, well, I'd probably best to avoid prednisone if I can.
And why did you decide not to go on the bisphosphonates?
I haven't actually decided that. I've been adding so many drugs one at a time here. I just added Crestor because Snuffy feels that it's a miracle cure. So I figured, what the hell, So I added Crestor, and the week before that I added enzalutamide, and the week before that I added, Xofigo. So I probably will go on Xgeva or one. I just, just too much too soon here. I just, feel like I want to space things out a bit so I can tell what's causing the side effects.
Right. Okay. Thanks.
Let's just go back to it. Hold on a minute, Albert. Let's just go back to Xgeva for a second, because Mike asked about Xgeva or Zometa, and both those drugs have a very long half-life. So you can take a holiday from those drugs quite safely. Again, I don't want to be giving medical advice, so please check this with your doctor. But because the half-life is so long, if you don't get a shot or an infusion for a period of time, you're not going to lose much. The half-life is about 2 to 2.5 years in those drugs. Now, there is an issue around them, and that they do make, even though they make your bones more dense and more difficult for the cancer to spread, they also make your bones more brittle. And so it's not a bad idea to talk to your doctor about taking a break. And the doctor should be aware that that the half-life is long. So if any of you have been on your bisphosphonates continuously for 3 or 4 years, I would definitely suggest you address that issue with your medical oncologists.
Yeah, the other thing is they've only studied a couple of the biphosphonates. I mean, the one that the cheapest and easiest way on biphosphonates is something called Fosamax, which is used in menopausal women and in men who are prone to fractures with osteoporosis quite a bit. And when I was in practice, I used that a lot. It's just a pill you take every day. And then they started coming up with some of the more designer biphosphonates and Boniva, which is the latest in the miracle ones. You only take every 6 months, or maybe it's once a year. I don't know. But the problem is none of them have been really shown to prevent fractures for osteoporosis. But on the other side of that, in the presence of prostate cancer, they have been shown to prevent skeletal-related events. These things you read about called SREs, skeletal-related events, which is basically fractures of the spine or hips and so on. So this is the one situation where they seem to really work to prevent a fracture, as opposed to osteoporosis, which everybody gets when they get older, especially women. So these drugs, I don't know. I was thinking going on Boniva, just because it's only every 6 months, and that way I don't have to go in every month. But my docs seem to want to go with Xgeva for some reason.
Well, I mean, the difference between these drugs is related to how much you retain. So when you take Fosamax, at least this is what I was told, you only retain between 0.5% and 1% of the total amount. On the other hand, if you go all the way to Zometa, the retention is, I can't remember the percentage, but it's very, very high. So that's the reason why Zometa is used for in the cancer arena, as is Xgeva, because you hold so much more of the active ingredient.
And that's what the answer the oncologist will give you. But just let me tell you that since Fosamax is generic and cheap, pennies a pill, there were no studies done looking at that as the control. It was only done on the more expensive patented brands. And so that's the reason you don't see the study comparing Fosamax to Xgeva or Boniva or any of these. But we're stuck with it. That's what it is. Mm-hmm. This is, medicine is the money-making industry, and unfortunately, I think on the other side of that, taking an infusion or a shot once a month is a lot easier than taking a pill every day, in my mind, anyway. So
especially Fosamax, because you have to take it so many early in the morning and so many hours before you eat and everything. So it's not an easy drug to take.
It's not. So I think convenience-wise, it's fine, and it's certainly more expensive. But I think unfortunately, that study using Fosamax will never be done. It's like the study on metformin. There's just no money to be made in studying these older drugs.
That's right. That's right. Albert,
I give my Zometa infused.
Hold on a second, Ron, and I'll come back to you. Albert, you had a question.
Yes, Rick or Steve. Steve, you mentioned Crestor, and I'm not familiar with that at all. Could somebody send some information out yet, or just briefly discuss it? I can look it up after the meeting.
Okay, so let me just give you a quick one, and then I'll move it over to Steve so he can fill in the gaps. Crestor is a fairly potent statin. Are you familiar with statins, Albert?
Yes, I am. Okay.
So Crestor is just another statin, but it's the one that's favored by Snuffy Myers and others. And one of the reasons that they recommend statins for in the context of prostate cancer is because the cancer has the ability to break down cholesterol and extract testosterone from the cholesterol. And so the less cholesterol we produce, the less chance there is for the less opportunity there is for the cancer to be feeding off of the cholesterol. And so it's generally recommended that if you are if you have prostate cancer, it's a good idea to add a statin. I'm not sure why Crestor is more effective than simvastatin, which I take, or whatever anybody else takes. But that's the general theory. Steve?
Yeah, no, that's exactly right. In fact, it's not actually feed off of. These are called 17-hydroxysteroids. The actual chemical cholesterol, when you look at it, is very similar to testosterone, which is very similar to estrogen. So cholesterol is actually very similar in structure chemically to all of the sex steroids, the estrogen, testosterone, progesterone, and so on. And so, so the theory is somehow the cancer cells mutate in a way that it can use the higher levels of cholesterol or the precursors of cholesterol to make testosterone within the cell, the cancer cell. So I did find something that was, I sent it to you, Rick. I remember it was, I don't know where, I could probably find it on my emails, but I was just reading through this because I had done a gene sequencing a couple of weeks ago with Foundation Medicine, and they found a mutation called PTEN, P10. And among the things that were scientifically, so you look into this, is that they did recommend statins for that mutation for some reason, and they had an explanation that I didn't really understand. I sent it to you, Rick. It was kind of convoluted. I don't know. Anyway, the only reason I'm taking it is because Snuffy Myers gives it out like candy, and I figure, well, what the hell? I'm on so many other toxic drugs. What the hell, you know?
And by the way, if you're at Kaiser, again, before you ask for Crestor, just check your drug policy, because it's a labeled drug. It's not a generic, and they could be charging you quite a bit of money for the Crestor, whereas perhaps if you took another statin that might not be as effective, or it may even be more effective, we just don't know, you wouldn't be paying so much.
Right. The Crestor, although in the big scheme of things, it's non-formulary for Kaiser, and if it's in your formulary, it's no big deal. But Lipitor is the statin most commonly used, and it turns out Crestor costs about $150 a month. So in the big scale of things, it's like that's not much money. And I was able to talk my my internal medicine, primary care doctor into just saying, oh yeah, I've known him for 25 years. I said, just prescribe it and put on when you get the flag saying, well, why are you prescribing a non-formulary? I just say, because Steve Bornstein told you to. And that's probably enough, In other words, that's one of the reasons you can do it. It's not a big...
Right. So Ron,
just by way of comparison...
Ron Shaheen, when you ask for Crestor, just tell the doc that Steve Bornstein says it's okay, all right?
Right, I got that.
Okay.
Patient insists. That's what you want.
Ron, I want to come back to you because you had a comment, then we'll go to Jake.
Well, my Zometa infusion I get once a month or every 3 weeks or so when I get my chemo. So it's easy. It's and they just it's just another sack of stuff that they put in my veins. So.
Jake, you had something?
I was just going to say, by way of comparison, if your doctor doesn't take Dr. Steve's advice and recommend Crestor, I take atorvastatin, which is Lipitor generic, and it's like $3 for 90 days supply. So.
Yeah, and it probably works equally well. The only reason I say Crestor is because Snuffy Myers insists that that's the only one that works. And that's.
Well, I was taking it all along because of the cholesterol, but.
Yeah. It all should work the same.
Now,
so, yeah,
I want to jump over to Thibaut. Thibaut, did you have some questions around Xtandi and enzalutamide?
Yeah, I've got some symptoms that are probably unrelated. My doctors don't see a connection. And they're all problems that I've had, pains that I've had at some point before I was diagnosed with cancer. It just seems like they've come back since I started the enzalutamide, worse than before. I have plantar fasciitis and stiffness in the hips, which they've diagnosed as arthritis, and I have rotator cuff tendonitis in both shoulders, and the pain from that is worse at night. And I also have pain in my forearms, like in the tendons, when I get up at night, but I don't feel it in the daytime at all. So I don't know whether there's a connection between all these things, or I just have all these separate problems.
No, I think there is a connection, and the connection may not be just that you've started the enzalutamide, but more that you've been on hormone therapy for a while, because there are issues. Joint-related pain is associated with hormone therapy, as is tendon pain. And so, some of what you might be going through is could be attributable there, and that's something that's probably worth discussing with your lady at George Washington, or with Antonakis at Hopkins.
Yeah, that makes sense, because I was only on ADT for like 5 months before I switched over to the enzalutamide. And I think I was feeling it then. It's just progressive.
Now, I'm not a doc, but I can tell you one thing, because I discovered last year that I have pretty compromised hips, but they're bone on bone. I don't have a huge amount of pain, but if I wanted to get new hips right now, Kaiser would pay for it. And what I've been doing is a lot of stretching. And I find that if I'm pretty religious about stretching before and after I exercise, that it definitely helps. And when I wake up in the morning, if I stretch, there's a definite benefit. So one of the things, again, that you might ask for is to speak to a physiotherapist and to talk to them about what sort of stretches you might do, because you're experiencing some side effects.
The other thing, Rick, people have heard the expression, even hypochondriacs get sick. It applies there. You always think that everything has to be related either to the cancer or the treatment of it. But, we're old guys, and you get a lot of aches and pains from being an old guy. I used to get a lot of back pain 10 years ago. I don't think it was probably prostate cancer, and I get tennis elbow now and then, and my shoulder hurts when I serve too hard. And, I think that's just a sort of a fact of life of aging, too, so you can't always blame everything on cancer or treatment.
Well, but I would say, but unfortunately, Thibaut isn't quite as old as we are. So, how old are you, Thibaut? 47?
45.
45. Yeah.
Well, you're pretty young for sure, but even at 45, you can get some aches and pains that are not cancer related.
But I definitely think that, just as, because I'm very much in favor of anything that's complementary if it might work. I was talking to a guy earlier on today who just started hormone therapy and is concerned about the hot flashes, and I said to him, try some acupuncture, because a couple of guys are saying that they're getting some real benefit from acupuncture, and so if you could get some benefit in all of this from doing some stretching, some people don't like to stretch. I'm one of them. And it takes some discipline. It takes even more discipline if you're not going to exercise, because, at least if you're going to exercise, you do the stretches as part of your exercise. But if you're not a regular exerciser, then, it's maybe a little tougher. But I really think that doing the stretches may make a difference for you, Thibaut. You've got to get with somebody to set out a stretching plan for you.
Yeah, I just need to remember to do it.
So, one of the things for you might be this MAN plan. Have you thought about signing up for the MAN plan?
I don't know what that is.
So the MAN plan, I don't know if anybody's signed up here or has got their package yet, and if they have, I'll ask them to speak when I'm done, after I've explained it. But the MAN plan is a program that AbbVie, who make Lupron, have started, where they have created a home-based exercise program for men who are on hormone therapy. And you sign up, they send you a package, and they send you an exercise program, and they make available counselors who you can talk to. They encourage you to comply. From what I understand, it's a sort of 4 to 6 week first phase, and then when you get through that, they have a second phase and so on. So it doesn't cost you anything. And let me put the URL in. I'll post the URL in the chat box. But it's the MAN plan, and what you do is you go to the URL, to the website, you fill out the form, and you need an authorization code. And then when you are asked for the authorization code, you telephone them and tell them that you're with Answer Cancer Foundation, and then they will give you an authorization code. We have a deal going with them. When I say a deal, I mean they're doing a test and they're working with us. So we've referred quite a few guys over to them. So let me first of all, does anybody other than Thibaut, are you on? Can you see the? No, you're on the phone today, huh?
Right.
Okay, so let me give you the telephone number. Then it's 844-295-7526, and the URL is boom, 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 boom. Just bear with me. The URL is themanplan.com, all one word, themanplan.com. So
okay, cool.
So you can do that. And is there anybody else interested who is on the web? If so, I'll post it in the box. Okay. So is anybody signed up for the MAN plan and gotten a package yet?
I went on the website this morning,
Okay.
actually after I saw my oncologist, and signed up. So I haven't got anything yet, but I'm going to do it.
And did you call the number and they gave you the authorization code?
No, because I wanted to wait. I ran into this program, so I needed to wait till we were done.
Okay.
But I got everything all ready to go. So
okay.
That's the website.
Okay, yeah, great. So anyone else? Has anyone else on here got a package yet? Well, I do encourage you to do it, and especially if you can combine it with, like Thibaut, you're stiff, and you can combine it with some stretching. What I was going to say is you could always ask them if they could come up with some stretching for you. They may have stretches as part of their program, but I don't know anybody who's actually got. I know a couple of people who have gotten the packages, but now they've got to start. And this is always the issue with exercise. It's It's all about compliance, and the program that we started at UCSF has good compliance. And one of the things that the MAN plan is hoping for is that the people that sign up will have good compliance too. But it seems to me that in order to get compliance, they've got to be pushing you. And I know that some of you guys have taken the first step, but not gone beyond that. I just want to say hello to Haley. Excuse me, guys. I just want to say hello to Haley.
I'm going to step out for a second here to feed her. She's going to drive me nuts.
Okay. All right. Okay. I thought maybe she was going to come in and sit in Steve's chair and take over. But for those of you who
guys,
Haley is Steve's dog. Okay. So
listen, Rick, I've got a question about the fact that most of us lose a lot of muscle mass.
Right.
We exercise to try to maintain what we have, but it's a losing battle. I mean, you can't build muscle when you're on ADT and some of these other drugs. And I'm wondering, I don't know what the physiological relationship is between muscle and tendons and connective tissue. Whether the loss of muscle mass accelerates things like arthritis or loss of pain and other connective tissue issues. It could well be. I mean, I feel it when I do weight rowing exercises and stuff. I can feel my hands, reacting a little bit where they maybe not used to do that in terms of grip and so forth. So I don't know. I'm just theorizing here.
I mean, look, I can only talk from my own experience. I was able to lift more weight, and I built more muscle whilst I was on ADT than afterwards. And I think that was because I was religious about lifting weights every 3 times a week. And I mean, I can't even use the sort of weight, come close to using the sort of weight with some of my exercises. Some I still can. I mean, my leg press, I can do the same. I can't bench press what I was bench pressing then. So all I want to say is that yes, maybe the hormone therapy dissipates muscle. It does dissipate muscle, but I think you can maintain it if you're willing to put the time in to do the weight resistance work. I mean, that's just my own personal experience.
I definitely agree with that, but I'm just theorizing that maybe the loss of some muscle might interact some way with the other connective tissues and exacerbates, and cause some pain in there. That's all I'm saying.
I think it does, Peter. I think it does, Peter, because they talk about, they cite tendon issues as being a side effect of hormone therapy. So clearly the lack of testosterone is doing something negative to your tendons. But what the level of that is, I don't think they know. There just hasn't been enough study on ADT and hormone therapy. There's a really big study going on right now that Movember is funding, and it's in Australia, it's in the US. I can't remember where in the US. It's in the UK. But I wish I could be more. I wish I could give you more, more detail. I can't. You could write to. You could drop June Chan a line at UCSF. She would have information for you. June Chan or Stacy Kenfield are the 2 people that are pretty expert, and they may have, or another guy that I know there whose name I could give you, Jack. I can't remember his last name. I'll send it to you. He's a good guy, and he might respond to you. So we're sort of jumping around today, but it's okay because I'm trying to make sure that we cover all the issues that people have raised. We haven't talked too much yet about fatigue, and I'd like to do that. Both Ron and Tom Van Zandt were concerned about fatigue. Tom, do you want to talk a little bit about your fatigue, and Ron about your fatigue, and maybe we can expand that a little bit?
Yeah, just, I mean, I don't sleep very well at night. I wake up a lot. I have trouble getting to sleep. I usually don't get to sleep till 1:32 in the morning. Then in the mornings I'm tired. I get up and I eat, and I might do a little bit. By noon I'm ready to sleep again, and sometimes I fall into a really deep sleep for an hour or 2. It's almost like death. Then you do a little more, and then every time I eat again, it's fall asleep again. Very little energy. I get up with a list of things I want to do, and the list keeps growing longer, and not much gets done. I do lift some weights. I walk a dog at least a mile a day, if not more. I try to do more if I'm feeling better, but at least a mile a day. And I don't know, just very low energy, a lot of fatigue.
Well, I just want to tell you that I did the same thing when I was on hormone. How long have you been on the hormone therapy now?
Since 2013.
Yeah. So, you know, once I would say that when I got about 12 to 15 months out, I was coming home and sleeping every day I was exercising, and then it just wiped me out. I'd come home and I'd sleep, and then I'd get up and I'd have enough energy to make it through the rest of the day. So, I mean, I do think it's associated with the hormone therapy. The fact that you're exercising is great, but I think that probably, you know, once you exercise, you come home, you sleep, how's your energy at that point? Oh, it's good enough to keep you up till 2 a.m.
You know,
A lot of times I feel very tired at, say, 9:30 at night.
Yeah.
But I've already tried going to sleep at that time, and then I'll wake up at midnight wide awake. So I try and keep myself up, and then around 10:30 or so, I become wide awake, whether I like it or not. Even though I fought that sleep earlier.
Yeah.
And then I'm up to 1.
Go ahead, Steve.
I carry around a Fitbit with me. I have for quite a few years, which is this little device on your wrist, and it tracks your sleep automatically. And I don't know if you can see this. I'm trying to get my webcam to show it, but all the lines here, if you can see that the light blue lines are restless sleep, and the red ones are awake, and the deep blue ones are deep sleep. And I can go day to day here on this thing, and this is, I notice, like here's another day, here's another day. All these lines indicate restlessness, and it's increased dramatically since the ADT. Of course, I was, diagnosed with cancer and been on 1,000 other drugs as well. But it's interesting. I mean, you can actually, wearing a Fitbit, you can see how well you're sleeping. And I have no money in Fitbit, the company, but it's very interesting. I look at this every morning, and I say, shit, man, I was up half the night. I felt like I wake up at 7 or 7:30, and I feel like, I guess I slept okay, but my sleep patterns 2 years ago, it was more solid blue. So I do think the ADT, I'm on Lupron, does affect your sleep patterns, and you get a lot of restless sleep, and you don't feel rested, and you're tired during the day, and et cetera, et cetera. Now, so this just documents what you're saying. For me, you just don't sleep well on ADT, I think. And I've tried Ativan and Ambien and marijuana, vape cigarettes, and all kinds of other stuff. My daughter bought me a vape, a THC cigarette thing. I don't know if you've ever seen those things. If you have a marijuana card, you can buy one, and they're cool, and you definitely get high, that's for sure. But I don't know if it helps you sleep. I mean, it's definitely cool though, Anyway, I tried those things, and it didn't help me.
So,
well, go ahead, Richard. My fatigue is a little different. I had a good 4.5 years of hormonal therapy on Snuffy's triple blockade, and I appreciate the fact I had 4.5 years of below number PSA, but I did not have fatigue from it. This Friday I will have my 11th consecutive chemo, and saw my oncologist today, and my big complaint was that I seemed to be getting more and more fatigue. And his response was that chemo, you and all the wearing down your blood, cells and those kind of things. But he also said that after 6 cycles, they usually recommend reducing the dosage, cutting back the dosage of the chemo. And I've been vehemently against that because I wanted to throw everything I could at this son of a bitch. And I have maintained. But he says that maybe after the next couple of times or whenever, it may be at the time to reduce the dosage of my chemo. Richard left, but he would be happy to hear that the oncologist said I really got to get back to exercising some more. And I used to walk 3 times a week before the chemo, and since the chemo I haven't walked hardly at all. So he says, you know, even if it's 10 or 15 minutes a couple of times a day, he says you really need to do that. That will help out your appetite. It'll help out your bowel movements. It'll help out a lot of things. So I came back from him motivated to start exercising again. And again, Richard's gone, but I went online and I picked up his Man Plan thing, and I'm going to participate in that and force myself to exercise some more.
I heard you.
Okay, well that's good.
I could hear you. That's why I unplugged, so I could listen to you whilst I was doing what I had.
All right, so that's all good stuff, but whether it's through hormonal therapy, the advanced hormonal therapy drugs now that have come out, or chemo, I mean, fatigue becomes a significant benefit or a side effect that we have in this prostate cancer. And I can say that over the 11 months now that my lack of exercise has probably been an assistance to my fatigue.
Mm-hmm. Well, you know, it's interesting because you've heard me say that so many times.
Right.
And it's great when the doctor says it to you, because then I can say you heard it here first. So,
right. From a Kaiser doctor.
From a Kaiser doctor, right.
Yeah, that's right.
Right, absolutely. I wanted to just come back to the sleep thing, because I could never really understand why my sleep patterns significantly changed when I was on hormone therapy. I mean, I always used to go to bed pretty late. I'd get up around 7 o'clock. I'd sleep very well. I never had any sleep issues at all. But after I got done with hormone therapy, my sleep patterns changed significantly. I slept much longer. I probably sleep an hour to an hour and a half longer than I used to. And I wake up oftentimes feeling absolutely wiped out, like a Mack truck hit me. I mean, I don't wake up feeling refreshed at all. And one of the things that I learned from asking questions about this, and Steve, why you have so much more restless sleep, is because the lack of testosterone causes you to wake up, even if they're very slight hot flashes, for example. That will disturb your sleep, and maybe not enough to wake you up, but enough to get you out of a deep sleep into a less deep sleep, and that's attributable to the hormone therapy.
No, and you know, the other thing is, I go back to menopausal women. The most common complaint that I used to hear as a gynecologist was sleeplessness, hot flashes, and irritability. And what does that sound like, right? I mean, you know, the lack of steroid hormones, whether it's estrogen or testosterone, I think just results in that. The interesting thing is, and I always used to tell women this, it usually only lasts for less than 10 years, okay? It gets better. Most women after 10 years no longer have hot flashes, and they're sleeping better, and they're not so irritable, or they're divorced, one or the other, you know? But, you know, it's very similar to a menopausal woman in terms of the symptoms.
Absolutely.
And, of course, what do you do with that? Sometimes if it's bad enough, you replace estrogen hormone, right?
Right.
So that's, you don't want to take testosterone with prostate cancer, but I bet all of these symptoms, if you just took a little testosterone, you'd feel a lot better.
Well, I don't want to say you don't want to take testosterone with prostate cancer anymore, because there are these bipolar, as we heard last week from Frank Kelly. There are a bunch of bipolar testosterone trials going on right now. Are you still considering a bipolar testosterone trial, Thibault? Oh, no Thibault. Oh, well, he's probably put the phone down and walked away. His kids are probably crying or got to deal with him.
Sorry,
oh, there you go.
I was on mute with the phone locked.
Oh, okay.
Yeah, I haven't heard anything bad about it yet. You may have more information than I have, but last time I talked to Dr. Antanarakis, that was our plan for after the enzalutamide failed.
Well, there is a trial. There's a trial going on at University of Washington, and one of our guys who lives in Idaho, his local medical oncologist has been in touch with them, and they're basically mirroring that trial. And he got his first dose of testosterone last week, and essentially he's like 2 weeks on the testosterone and then 2 weeks off the testosterone. And the idea is that the testosterone resensitizes the androgen receptors, and so it makes the other drugs that he's taking more likely to work. In a nutshell, is that, Peter? Would you add anything to that from what Frank said last week?
No, that's pretty much the way I understood it. 2 weeks on, 2 weeks off, and but I don't think he's been on long enough to really know what the effect has been yet.
Right.
It'd be interesting to get him a Fitbit or something and see how he's sleeping on the testosterone, because I bet you'll see a lot of dark blue and less restless sleep. And this is all very much hormonal. And, if you don't sleep, you're tired all the time. I mean, and that's the bottom line for me.
Well, he wasn't too happy after the first 3 or 4 days that he'd been taking it. He said it was making him miserable. So I don't know. But, Frank will be on the calls on a pretty regular basis. So we certainly are eager to talk to him. Thibaut, you didn't tell us, how are you doing on that enzalutamide? How's your PSA? What are we seeing off of it?
My PSA before I started in February was 20, and it has gone down to 7.
Oh, good.
And it's been stable at 7 for the last 3 months.
Oh, good. Oh, good. And other than these pains and these muscle and joint pains, you seem to be tolerating it in other ways, okay?
Yeah, I've got a little bit of fatigue, but not too bad.
Okay.
That's probably the ADT.
Or the kids being more demanding.
Yeah, when I'm playing with them, they want me to push them around in their car, and I can do that for about a minute, and then I got to sit down and rest before I can do it again.
I see. So is there more activity? Is there more activity in your new location than in your old location?
No, I've still got a backyard just like I had before.
Okay.
And the amount of walking I have to the metro is equivalent to the walking I had before from the car to work. So it's about the same.
Mm-hmm.
I do 3 or 4 miles a day total.
Mm-hmm. 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 Peter, you had something?
If you can push your kids around in their car, that's pretty amazing. Why don't you get your kids a better car so it doesn't break down as much?
They also have electric cars, but they think it's more fun to get in the non-electric car and get me to push. And that's not on pavement, that's over grass, so it makes it even harder. And that's my exercise, is playing with the kids. They will never tire, and so I'm always the first one to say, okay, time to go watch some cartoons.
Well, this fatigue problem, and Peter, you wanted to talk a little bit about brain fog. And brain fog, there was an interesting article that I have bookmarked, which suggested that one of the reasons why we have brain fog from hormone therapy is because it arises out of a mixture of fatigue, lack of sleep, and the feeling of fatigue during the day, lack of sleep, and depression. And even if we don't think we're depressed, our brain chemistry has changed because of the lack of testosterone. So all of those together create lupron brain, which is a lot similar to chemo brain. And yeah, I mean, some people suffer much more heavily than others. So I mean, I think that one of the best things to do, certainly for me, that I found was to challenge my brain every day by doing. I used to play bridge on the computer. I used to try and play a rubber a night on the computer. Some people do crossword puzzles. Some people play Sudoku, but they all are really good to keep you forcing yourself to use your memory and use your brain. I mean, I think it works. I mean, now of course there are all these brain apps that we see advertised all the time, you know, to do the testing and what have you. But anybody else want to say anything about chemo, about lupron brain?
Well, you know, there was a study that came out about a year ago that showed that ADT was associated with not just lupron brain, but true dementia, as in Alzheimer's dementia.
Yeah, I saw that.
You know, and based on MRI studies, so I had the classic changes of dementia, and so I think you're dealing, you know, somewhat with, sleeping well and all the other factors that might go into it. But you know, I think it does promote dementia, and if you live long enough, that may be what we're looking at here. I mean, if you're fortunate enough to live that long, I
think that dementia study was debunked a little bit. I'd have to go back and look. I do remember when it came out, but I think there was, I need to go in and look, Steve. I can't do it right now, but I think there was some, first of all, I think it was a very small, I think it was barely statistically significant, if at all, but there was quite a lot of discussion. Go ahead.
No, it hit the newspapers, you know, quite a bit, probably a little less than a year ago. And I did read it, actually, and as I recall, they kind of did a little bit of hand jive with the numbers. You know, a 7-time greater incidence of dementia on men on ADT, I think is what they were quoting, but the numbers were small. You're right, Rick. But, and I'm not saying everyone on ADT is going to get dementia, but I think it's a concern for sure. You know, I mean, as people live longer on ADT, it's a concern.
I think that chemo brain is certainly the next step after the ADT brain. But I guess something is, you know, we always wonder at 73 whether it's the chemo or just me having short-term memory. And as we talked about other aches and pains and things, I'm constantly trying to weigh a pain in my arm that I wake up in the morning with, or on my chest, and say, okay, now is this a Met that's starting to give me some bone pain, or is this just Ron Shaheen being an old man? I think with that, when it comes to short-term memory, trying to grab the name of this actor we just saw in a movie, you know, all these other little things that we're all experiencing now. My wife wants to say it's chemo brain and don't do anything financial. But you know, I think it's all real. But you know, whether it's hormonal drugs that we're taking or chemotherapy, you know, we're putting a lot of crap in our systems. And my concern and my conversation with my oncologist today was, yeah, this poison I'm putting in me is effectively reducing my prostate cancer, but what the hell is it doing to the rest of my body? You know, and how long can I, is it affecting my heart? Is it affecting my liver? What else is it doing? And that's when he got back on his case about reducing the amount of the chemo that I'm having, from a full strength to a reduced amount.
So I just one second, Peter. I just posted in the chat box the link to the review of the study that appeared on Prostate Cancer International. And for those of you who are on the phone, if you go to Prostate Cancer International and you search for ADT and dementia, it'll come right up. So I'm sorry, Peter, go ahead.
Yeah, my concern really is with what we're just talking about, short-term memory and so forth, because I've noticed a difference this round of ADT. At the PCRI conference, my medical oncologist, Dr. Turner from Marina Del Rey, was doing a session on ADT, and I asked this specific question to him because I was starting to get concerned about short-term memory loss. I mean, the other day I was talking to someone, and for the life of me, I could not remember one of my 4 grandchildren's names, and it started really bugging me when it just slipped my mind, and it took me about 5 minutes to catch up and realize what her name was. Of course, she doesn't live with me, so I don't see her all the time. It was a relative, and then a close relative. It was my granddaughter. So I'm starting to notice that there is some of this. And Dr. Turner's comment was that after ADT, if you get off of it, your short-term memory does come back considerably. And I don't know this. I mean, Rick, you were on ADT for a while, and then you went off. I'm hoping in December that I'm going to go off and have a vacation from it for a while.
Right.
And I'm kind of anxious to see whether there is a difference, whether it is a temporary thing that goes on or whether it's permanent obstruction happening.
Well, I mean, it did come back. It took a while. I would say it took probably a good year for me to feel like my maybe even longer, maybe 18 months for me to feel like my mind was kind of back to normal. What I would say is, though, that if you're not doing it, Peter, try and do exercises every day or games every day that force you to use that memory. I mean, one of the reasons I wanted to, I play bridge, or I used to play bridge, but one of the reasons why I chose bridge rather than Sudoku was because it forces you to use your memory, because you've got to remember what cards have been played. So you're focused in on that. So I think you'll find that if you do some of those exercises might help. At the same time, yeah, I mean, I get the same thing. I'm talking to somebody who I know very well, and I can't even remember their name, and then 5 minutes later it comes back to me. And things you absolutely know you know.
2 weeks ago, I was talking to somebody. I'd just seen the movie Sully, and I was telling people about that, and I said, yeah, this is my favorite actor. And it Tom Hanks' name just would not come up. I couldn't get it.
Right. I think this is it's fairly common. And there are things just like with the exercise for your muscle deterioration that you can do that will help. And I just recommend that you do it. I think it makes a difference. My former buddy Dick Lasses plays Sudoku every single day with his wife, and other games, and it's a good exercise.
Right. I do some of that, and I realize that I might just put as an aside, and I think probably we all would agree, one of the great exercises is this phone call every week, or twice a week, or however many times we participate, because it does keep you sharp. Maybe it keeps you remembering names of drugs and remembering names of buddies and everything else. But it's great to keep us sharp and engaged.
Yeah. I mean, I initially once I when I started to moderate these calls, I was absolutely wiped, and it was I probably started to do this sort of moderation about a year and a half or so after I came off the hormone therapy, and I really feel it. Now it doesn't bother me so much, but to begin with, I was just exhausted when I came off the calls. Exhausted. So if that's how you're feeling after you do your calls, Peter, I think it's very understandable and very normal.
No, I don't feel exhaustion. I've gotten past the exhaustion thing. I'm on Casodex and Lupron, and I've been on it for 10 months now. Now this round, and I was on 7 months before that with a vacation. But I've beaten the fatigue factor, mostly the fear of, is this memory loss thing going to be a permanent thing, or is it actually going to come back to some degree? That's what scares me a little bit.
So,
I'll tell you something that I would recommend is that I've been doing for several years since I retired is this thing called the Great Courses. I don't know if any of you are aware of that, but these are college courses taught by famous college professors around, and just a multitude of topics. But each of their lectures is about 30 minutes, but just listening to one of those lectures and trying to follow it and remember some of that stuff is a good exercise.
Yeah. I see that we may have a couple of extra people that have joined us. So let me just run down who's here. I know that we have Tom Van Zandt, Steve Bornstein, Ron Shaheen, Peter Kafka. Albert had to leave. He left us a message in the chat box. Mike Tamales, Thibault Lincecum, Len Sierra, Jake Hannum. Anybody else? Anyone whose name I just did not call? Okay. So I'm going to leave the sound on, but I'm going to pass the moderation over to Peter and to Steve, because I have to get myself ready for start getting ready for Yom Kippur, which means I've got to eat pretty soon, because I've got to be out of the house by about 6 o'clock. So I'm just going to listen in, and I think we've covered on my list most things other than neuropathy, which I know Jake wanted to talk a little bit about, and Len, who wants to give us an update on a very good imaging lecture that he listened to from Mike Morris at Memorial Sloan Kettering at an Us Two meeting in New York about a month ago now. Other than that, if there's no one else who still has something that they want us to raise, I think those are the two things. So maybe I can leave you with Jake and neuropathy, and then you can segue from there into Len's discussion on imaging.
So, Rick, light a candle for all of us, will you?
I will. Believe me, I will. I do. Every time I go, I mention everybody here, and I'll be thinking of you today and tomorrow, and you be thinking of me when just about this time tomorrow, when I'm absolutely starving and I'm desperate for a cup of tea. Okay.
No, this requires a fasting.
Rick, I'm going to be seeing Dick and Christine today or tomorrow.
Okay.
Hi, Rick. I would much rather.
Jake, you're on.
Okay. I won't take much time. I'd much rather hear from Len, because I know he wanted to talk last time. But I was just, and this doesn't happen all the time, but I think I have neuropathy. I may be wrong. It may be something different. But my left foot especially just seems like it's always cold. Not both feet so much, but my left foot and my big toe. I don't know. Has anybody had anything like that? Is that neuropathy? Is that something? Nothing else? Something else? Does anybody have any ideas?
Since I've been on chemo, the bottom of my feet, just the bottom, are semi-numb.
Right.
I don't feel this hardly at all during the day, but to your point, at night, my feet have gotten very cold. No matter what I do, blankets, my feet seem cold. So I started putting on thick socks at night, and it really helped the situation. But talking to my oncologist, definitely chemo creates, for your extremities, some tingling, numbness. Some of it is neuropathy. I can't even say that word, but is that. But some of it is like mine, which is minor. My fingers started tingling, and he told me to take B12. And I've been taking B12, and the B12 has really helped my fingers.
Well, that was always my understanding, was that that neuropathy is very common with chemo. But I'm not on chemo. I'm just taking Lupron and Casodex. And I was just wondering, you know, almost everybody here is on Lupron. Have they had that before they went to other treatments? Did they have any kind of symptoms like that? Tom says no.
I've had neuropathy for 10 or 12 years, which is primarily in a sort of a stocking area, bottom of the feet, like Ron was talking about, not so much the hands. Usually it's stocking glove is what's talked about. But it turns out that was the most common reason is diabetes, for sure. So if nothing else, you want to make sure you're not diabetic. That's a pretty obvious thing. But if it's not that, mine is probably more related over the years to chronic disc disease in my lumbosacral spine. Now that I've had multiple MRIs and CTs and so on, I've got two discs in the lumbosacral area. But when I went on chemo, not ADT as much, but on chemo, it got decidedly worse. So I decided I would do acupuncture every 4 weeks, or chemo's every 3 weeks or 4. I've forgotten now. Is it every 3 or 4? Every 3, yeah. So every 3 weeks, right before I had chemo, I would do acupuncture. And I do think that the acupuncture did help to make it so it didn't get worse.
Right.
And when I stopped the chemo, I stopped the acupuncture as well, and it did get worse. And now I'm about 6 months post-chemo, at least that, maybe a little more than that, and it seems to be getting a little better again. Primarily, you know, there's two types, just to tell you, two types of neuropathy. One is called sensory, which is the sensation, pins and needles, hot and cold, that kind of thing, and one is called motor. Once it gets to be a motor neuropathy, weakness, so that you can't step on the gas, you can't step on your tiptoes, that kind of thing, that's a much more serious thing.
Right. Oh, yeah.
It does progress sometimes to that, but that's when you see people stumbling and falling and having problems with gait, and they can't get around as well. So if it's sensory, usually it's not so disabling, but motor neuropathy can be much, much worse, and so you definitely don't want to. You want to check periodically, make sure you can stand on your tiptoes and you feel like you have good strength in your lower extremities to make sure it's not progressing to motor. Okay. But the acupuncture is the one thing. I did take B12 and B6 as well, and I tried the acupuncture. I do think the acupuncture actually did help. So if you have access to that, I don't think it hurts. You know, it certainly can't hurt you.
Okay. Well, thank you.
Jay,
another possibility is massage. You know, take the time to, you know, get a foot massage or a leg massage, and you know, and really work the muscles and the lymph nodes and whatever else is in there.
Increase circulation. That makes sense too. Yeah.
Jay, there is neuropathy is known as a side effect of hormone therapy. It's not that common, and I only found that out maybe a year or so ago. Because I've been suffering now for the last 5 years or so with a very unpleasant neuropathy, and it comes when the weather gets colder, and you know, it feels like either burning or somebody sticking a needle into my heels. Mostly I get it in my heels, and I get it fairly frequently through the winter, and once it starts, it usually lasts about 6 to 8 weeks. I haven't tried any of these remedies. I think this year I definitely will try, you know, B10 or something like that, and I haven't tried acupuncture, and that might be also something, but it is something that associated with the ADT.
The other thing, there is a drug called Lyrica, which is advertised heavily on TV for diabetic neuropathy,
Right.
And it has been tried with neuropathy related to chemotherapy, and I don't know how successful it is. It does have some side effects. It's Lyrica, Lyrica, but it is approved for use in diabetic neuropathy, and especially for this intense burning some people get in their feet, and they just can't sleep at night because they're just like the soles of their feet feel like they're on fire. And I know some docs that have put people on Lyrica and tried it, and I think if it gets bad enough to really want to try some conventional medication, Lyrica is one choice.
Okay. Yeah, right now it's not bad. It's just I'm afraid it's going to get worse. And
Yeah.
I'm not diabetic. I'm pre-diabetic for sure, and I am taking metformin. But
yeah.
So thank you very much.
Okay, Len, you're up. You got 15 minutes here.
Oh, that's plenty of time. But Peter, I wanted to say to you that when I went on intermittent hormone therapy, all of the side effects of the ADT were reversed over a period of 7 months. So I felt like my brain function was better. Definitely I was able to put more muscle mass back on. I had more energy. Even my testicles grew back to their normal size. So, something to look forward to for you in December when you go off therapy, hopefully. But getting back
That's
to
good news.
the
Good news.
yeah, the new imaging techniques in prostate cancer. The lecture given by Michael Morris, well-known oncologist at Sloan Kettering. Now, some of this, I know Steve, just from comments he made earlier, he knows already, but it was news to me that the earlier bone scans, like technetium-99, and then the new and improved sodium fluoride F18 bone scans, they're actually not even imaging tumor. They're just imaging bone growth that's associated with tumor metastasis in the bone. And so the bone growth, as Steve, I believe, mentioned earlier, the bone growth also occurs when the bone is recovering. So when the prostate cancer cells in the bone are dying due to therapy, and that's called flare. And Morris said that that can happen in about 50% of patients who are responding to treatment. So just because the scan is showing not new areas, but the same areas lighting up, doesn't mean you should discontinue treatment right away. So the newer technologies in scanning are not imaging the bone. They're actually imaging the tumor itself, whether it's in soft tissue or in the bone or visceral. And of course, all of us have heard of C11 choline, which are approved by the FDA for biochemical recurrence after failure of surgery or radiation therapy. And what most people think is that only Mayo Clinic is doing this, but I'm a patient at Sloan Kettering, and I was surprised to learn Morris says that Sloan Kettering is now doing this routinely. So if any of you guys happen to be, I don't think any of you are, but if you were in the Northeast area, you don't need to go all the way to Rochester for a C11 choline scan. Now, Sloan Kettering is also they have in trials 18 fluoride DHT, as in dihydrotestosterone PET scanning. So the radio tracer 18F DHT is, again, just like choline, picked up in bone mets and soft tissue mets. And the interesting thing here is that the DHT tracer can be used to distinguish the type of cancer cells. That is to say, whether or not they are hormone receptive. So the DHT will be picked up by hormone-sensitive tumor, whereas the if they're also giving you 18-fluoride FDG, which I think stands for fluorodeoxyglucose. So if it's picking up the glucose tracer but not the DHT, they speculate that this is because those tumors are hormone resistant. They spoke a little bit about the 68 gallium PSMA scanning. Some folks are wondering, like, why hasn't that been brought to the U.S.? And he explained that that's because it was developed in Germany, where they have publicly funded medical care. And so Germany, a patent not only gives you the right to use an invention, but it also, more importantly, it gives you the right to block others from using it. But in Germany, they said, okay, we've patented this, but anyone can use it. So that's bad for for us in the U.S. because there's no financial incentive for companies to develop the PSMA scans. However, Morris claims that he believes the U.S. companies will soon be adding a few bells and whistles to the PSMA scan that will enable them to patent a variation of PSMA, and then it will become available. And he thinks that PSMA is the best tracer available currently.
So then what does PSMA stand for? What does that stand for, PSMA?
PSMA? Oh, prostate-specific membrane antigen.
Oh, membrane antigen. Okay, right.
Right. So this is on every prostate cancer cell.
Right.
And where you probably heard that with choline, they like you to wait until your PSA has risen to at least 2. But with the PSMA scans, in patients with known metastatic disease, PSMA detects METs in 70% of those whose PSA is between 1 and 2, and 50% of those whose PSA values are as low as 0.1 and 0.2. So Sloan Kettering is also using PSMA scans in clinical trials for patients with advanced cancer. And you all guys probably also heard of the most recently approved scanning agent, Axumin, A-X-U-M-I-N, also known as fluciclovine, F-18. Morris believes that that is probably not quite as good as PSMA and might be a little bit better than C11 choline. Now that's it. That's the update on the newer scanning technologies.
So just to understand, these are mostly PET scans then, is that correct?
Yes.
It's the imaging study itself is a PET scan, not a CT. And
well, he describes it as PET-CT.
PET-CT scans, I see. So they're using a hybrid of both. And,
yes.
And to be used in place of a conventional CT to look for evidence of new metastases. Is that kind of what the gist of why they use them?
Yes, exactly.
That's right. Yeah. And is it more effective for not bony but visceral metastases as well, like to liver, or abdomen, or brain?
He didn't say it was more effective. He just said it was effective for both bone and soft tissue. Whereas the traditional technetium-99 or the sodium fluoride F-18 bone scans were strictly identifying growth in bone, not in soft tissue.
Well, bone scans and PET-CTs have always been two different things. I have a question, Len.
Well, an old technology, yes, absolutely.
All these different acronyms you used, most of them, like Dr. Steve said, most of them have to do with PET-CT. They're all imaging agents, correct? That are injected into your bloodstream for the test.
Yes, they're all imaging compounds.
Okay, so then do they have to have different? Do they have to have a different PET-CT machine for each of these chemicals, or do they just need to be recalibrated? what I'm getting at is why don't all PET-CT centers have all of these different, imaging compounds that they can just change depending on the patient? Understand what I'm saying?
Yeah, I understand, he did say something about when the FDA approved the C11 choline, for instance, it was only approved for use at the Mayo Clinic, and I don't remember the reasons why. But so they had exclusive rights.
Some of these agents require.
Go ahead.
Yeah, some of these agents require a cyclotron, and I believe Mayo has one, and also Phoenix Imaging has one, and also there's a factor, I think, of the half-life of some of these agents. So how fast they need to be used. You don't have a lot of time in between on some of them. I think the Mayo one has more time, but the Phoenix one has a very short time frame that you have to use it by. I think the advantage of the Oxymin thing is a much longer life, and they've got some more space. But the elaborate equipment, I don't. That was my question: is how much do these places need to have cyclotrons on site to be able to produce these agents? And is it still limited to a couple of big time facilities that can afford to have this and have the space and the funds and everything else to utilize it? I'm glad that Memorial Sloan Kettering is getting into the act so that you have a place on the East Coast, but that seems to be one of the drawbacks to my understanding.
Well, that makes sense.
Unfortunately, I don't know enough of the technology to answer your question, although I believe that a cyclotron is only used for treatment radiation, such as photons, IMRT, or SBRT, or proton therapy. I don't think you need those for imaging agents.
No, the way my understanding, and I'm not, an imaging person or a radiologist, but it's sort of like a transmitter-receiver situation. So the transmitter in this setting is going to be the C11 choline or the PCMA, or there's something that you can think of that you inject that's a molecule, whether it be a radionuclide or other molecule, that's received, that attaches very quickly to whatever area of the body you're talking about. Iodine-131 to the thyroid is the classic example. Radium-233 to the bone is another example. Those are radionuclides, but these substances you're talking about, whether they're radioactive or not, needs a specific receiver, and that's the money. So not all the receiver, like something that will image your thyroid, iodine-131 is not going to necessarily image something in your liver or your bone, depending on the transmitter molecule. So that's the piece of technology that becomes very expensive, I believe. I'm not sure where cyclotron would come into play here, quite frankly, Peter. I don't know how a cyclotron would be involved in any of this imaging stuff.
So in layman terms, what you're really saying is that the PET-CT scans are not generic. Each one would have to be specific to the chemical that they're using.
I think that is what the issue is. Otherwise, you'd see people just as soon as they came out with these newer, marker drugs, where they can, any
everybody
of these,
would have it.
Yeah, exactly. The surface membrane antigen is a great example. If that is attracted to prostate cancer or prostate cells only, then everyone would have this imaging. They wouldn't be doing bone scans and so on. That's my understanding. But the cost is in the newer technology to sort of receive that, to image that.
Right. You're talking hundreds of thousands, maybe even millions of dollars for each of these machines.
I have no idea. Hundreds of thousands wouldn't be that much in the big scale of how much things like a cyberknife or, a Varian machine and so on. In the big scheme of things, these are very expensive units. Yes.
Right.
But I would like to add, Peter, you were right about the very short half-life of the C11 choline. That triggered in my mind that Morris said that it has to be used within 20 minutes of the time they synthesize the chemicals, and only at the Mayo Clinic were they authorized to manufacture the C11 choline. So I guess eventually Sloan Kettering got a license to do that also. So you couldn't transport it anywhere from Mayo Clinic to any other institutions. So whoever is going to use C11 choline, they have to be manufacturing it right on site, the
Right.
radio tracer.
And that's where the cyclotron comes in, because in creating this this agent, it has to be spun, and so they have. I mean, I've seen it. I haven't seen it actually used, but I've seen the equipment. They have the equipment by the MRI machine, and they spin it, and then they have to transfer it into, I don't know if they drip it into you. I'm not exactly sure how they infuse it into you, but they have to move it into you very quickly between the time that they spin it. So that's where the cyclotron is. They have one at UCSF.
Yeah, that makes sense then. Yes.
Right. And I think that's the excitement about the Oxymin technique, because Oxymin seems to have a longer half-life and is transportable a little bit. Not a huge amount, but it gives it more flexibility and the possibility of getting these machines to more remote areas or more extensive areas. Because it seems it's great that UCSF and Memorial Sloan Kettering have finally gotten in. It seemed crazy to me that you had to go to Mayo in Minnesota or Phoenix to get imaging before on this detail. But now the possibility of Chicago or down south or in Texas or something like that is a possibility, which opens up a lot more available treatment to.
Although the question becomes, will your insurance cover that study? Most likely the insurance carrier is going to say it's not standard of care, that we don't offer it because it's not standard of care. Until these things become more available, then it's likely that you're going to be out of pocket.
Well, is that true now for C11 choline, or I thought that was reimbursable?
I don't know. I don't know.
Just one other thing.
It's reimbursable at Mayo, but it's reimbursable at Mayo, but if you go to Phoenix, you pay out of pocket.
Uh-huh.
Yeah, I mean, it's, there's certainly a lot more than the bone. The bone scan itself is a very crude test. If you've ever seen one being read, basically it's just like a picture of a skeleton, and they basically show areas where it's brighter, and it's a very crude and older test. One of the first radionuclide tests goes back, it's basically a Geiger counter is what it is, and so it's, once you had one, the value is in comparison one to the next, and the value of that is if there's new lesions, you can say whatever you're doing is not working. That's the only value of it. Seeing the same lesions means nothing.
Or they can miss lesions completely. When I had my bone scan, it showed it was clear, but I had already had metastases by that time. But the bone scan showed up clear.
And when you think about it, if you got circulating tumor cells and circulating tumor DNA, you've got microscopic metastasis in your bone from day one.
Right.
It's just a question of whether your immune system is taking care of that or not. And so at the point when you can pick it up, eventually they're going to say you've got one cell of cancer in your spine. Eventually, if the tests are sensitive enough, and the question is, well, now what do I do? Never order a test you don't want the result of, right? So because everybody has cancer everywhere, and it's your immune system that's protecting you, it's just that when you get a large enough accumulation of cells, then these imaging studies are able to see it. And whether that be a bone scan or a C11 PET or whatever, as they get more sensitive and get down to the level of, what if you could see one cell? What would you do then? I don't know.
Well, that would be the time to attack it. If you knew that you had one cell, that'd be the time to kill it.
Well, but on the other hand, you probably did 25 years ago, because and your immune system took care of that, right? So
right. The
problem is these cells mutate, and then your immune system, because of checkpoint inhibition, et cetera, that's going on, your immune system is no longer capable of recognizing these as cancer cells, and that's where we get into trouble. I mean, everyone has cancer cells developing all the time. It's just that your T cells are able to recognize them immediately and get rid of them. And that's why immunotherapy is so effective. If you can just turn your immune system back onto those cancer cells again with the stuff like the checkpoint inhibitors and so on. So to me, the imaging thing is interesting, but at what point do you say, I don't want to know if there's one cell there. I want to know if I have enough cells that my immune system is not working at that point.
If I have something that's going to kill me.
Yes, if I have something that's going to progress and kill me, exactly.
Len, is this presentation available, or was this non-recorded?
I remember that he said he was going to make it available to the group leader of that US2 chapter, but then I never heard from them that that they actually had it and they were going to make it available to the rest of us. But I will find out. Meanwhile,
I did listen, Lynn, to part of that, and I think they said on that, what's it, the Cancer Research Institute, CRI website, they would have all of these talks available.
Steve, this wasn't given at PCRI.
Oh, this wasn't? Well, this is the one in New York for the one-day thing, right?
That's right.
Yeah, no, this was, and the Cancer Research Institute was sponsoring this, and I listened to a few of the talks, and I thought they said it would be on their website, which is cancerresearch.org, I think, or something like that. I'm not, so I did remember them saying all of their talks would be available.
All of the talks from PCRI?
No, from the one-day New York session where the guy from Sloan Kettering and there was another guy from St. Luke's was there. And,
okay. That may very well be, and maybe Morris spoke there also, but I heard him speak at an US2 chapter meeting. It had nothing to do with that all day.
My mistake, yeah. Len. I thought this was at that New York meeting, that one-day meeting a few weeks ago. I see. Yeah.
We should look into that. This is a great subject, and it probably needs more time than we can give it here. But I'm glad you brought it up because there's all kinds of aspects to this, like not only the machine but the doctor. Why is there always like one doctor attached to these things, like Eugene Kwan and Mayo and Dr. Almeida and Phoenix, and there must be some kind of expertise or something in reading this, or maybe not, but it's really worth coming back and talking more about this subject. Maybe we can bring it up with Rick next week and see if this talk is available.
Yeah, and when it would be appropriate to do these in place of, let's say, a bone scan or CT.
Exactly.
Yeah.
Well, guys, it's
go Giants.
Past 2 hours.
Dodgers are winning in case you're listening to that, but go Giants, huh?
Okay. Yeah. Well, I wish them all good luck. As I said last night, especially the Cubs. After 108 years, they deserve a break.
They deserve it. My Cleveland Indians as well. They all deserve it, but only one's going to do it.
Guys, I just wanted to say, I'm not taking sides on any of the baseball, particularly this year, because as much as I like the Giants, I know how much it would mean to Dominic if the Cubs won. So
I was thinking the same thing.
Yeah, I know, and I actually was in touch with Cecilia this week, and they had one tree down. Thank God, no more damage than just one tree. And of course, she's glued to the TV. What I just did want to say to you is that I hope to moderate the meeting on Monday, but I may not. It really depends on whether I can stay up that long, because I've been flying overnight the night before, and the meeting won't start till 1 a.m. my time. So I'm going to send out the notice, but I may not be able to actually moderate it. So I've asked Peter to start the meeting, and if Steve, if you're around and you could give Peter some help on Monday, that would be great. And
we're all up at 1 in the morning. You know, Rick, you should be up at 1 in the morning. No problem for you.
I was going to say, I stay up till that late every day.
Yeah, hey, you know.
Well, you know, I would be up till 1 in the morning, but the problem is I won't have slept much the night before because I'll be flying from, I'm flying from here to London, and so I will have,
You get a pass.
you know.
You get a pass on this one.
So I may or may not, it depends, or I may take a nap and then I'll be fine. And but anyway, I just want to say that if I'm not, then I'm sure that you guys will ably step in and run a meeting. Okay, but anyway, enjoy whichever team you're following. Enjoy.
And safe travels, Rick.
Thanks a lot.
Yeah,
Okay.
safe travels.
Yes, travel safely.
Okay. All right. Goodbye, everybody. I'm going to close the meeting, Peter.
Good night.
Bye.
Adios.
Okay. Okay.
Thank you.